So the idea of this talk came is that many of us have become cataractologists, or people who just do cataracts, and if there is no cataract, there is no fun in the patient anymore. And we tend to bump them off. And if it's a patient who's got even something vaguely neuro-ophthalmological, you ask for a CT. If the patient can afford, you ask for an MRI, and then you send the patient off to your favorite not neuro-ophthalmologist, but a neurologist who knows nothing of ophthalmology. And then if you've done an MRI, he'll ask for an MRI with contrast or whatever. So there are many conditions in the eye where the neurologist is really not involved or doesn't come into play at this point. There are many things that we can diagnose as general ophthalmologists. Forget being, I've got a panel of neuro-ophthalmologists here with me, but as general ophthalmologists, which is my category, a lot of patients can be diagnosed by us ourselves without, with just basic tools that we have. We have perimeters, we have torches by which we can look at pupils, we know how to move the finger from one side to the other to see movements. And the amount of information you can get from patient moving his eye from one side to the other, or looking at the pupil and seeing differences, or just doing a simple perimetry and deriving information from there, you can come to many times an informed diagnosis and decide what next to be done, whether to be referred or not. So this is actually designed to prevent dementia in all of us by using our gray cells a little more. That is the object of this course. So usually we send our patients to the handful of neuro-ophthalmologists in the country, or if the patient is in a town or district place, we refer such cases to general neurologists who promptly order an MRI. So what you will learn today is how to use simple tools to diagnose why there is an unexplained visual loss, what a careful examination of ocular motility and pupils can tell you, how much information can be derived from simple visual fields, and which headaches can be diagnosed and treated without asking for MRI. You know, there are headaches, and there are actually a few headaches where you don't need an MRI. Sometimes you can even do something like refraction and find the patient has got +4, and if you'd only given him +4, that MRI could have been saved. So I'll introduce our co-instructors. The first gentleman needs no introduction. Rashmin Gandhi is a neuro-ophthalmologist. So is Naveen Jaikumar. Rashmin is from Hyderabad. Naveen is in Chennai. And Hemalini Samant is in Mumbai. And all of them will point out some of the facets of things that I told you about today. So let's get on with the course so that at the end of it, there are no surprises that we face. Thank you so much. You may clap now, and then I will start my talk. Now I have a second presentation. So let's start with medically unexplained visual loss. Patient has an eye like this, and patient says, I can't see. So it's a common problem. Most ophthalmologists are likely to encounter this problem in their practice. It consumes a large amount of resources and generates anxiety in patients and their carers. So we need to find out where, right from the cornea at the tip to the occipital cortex at the back, where lies the pathology. At least that much we should be able to decide in a patient with medically unexplained visual loss. So where is the problem? Is it in the refractive? Is it a refractive issue somewhere in the media? Is it in the retina choroid? ऐसा नहीं था ना, because मेरा हाथ दूरजता है ना, tremors, they come to know. So is it in the retina choroid? Is it in the optic nerve or visual pathway? Or is it a non-organic thing? So let's see if we can identify these. So refractive causes, irregular astigmatism. So start with looking for irregular astigmatism. I still use my slit retinoscope and look for the astigmatism, see if there is a scissor shadow that I'm missing out. An oil drop cataract, a small cataract in the center, which only when you dilate you will see. Is there any occult corneal disease? So take the patient on slit lamp and look at him layer by layer on a decent slit lamp. Easiest thing to evaluate is by pinhole. If there is irregular astigmatism and patient 660, but you put a pinhole there and he sees 6/9, then you know that there is something in the cornea or in the media which is causing this, because the pinhole eliminates the astigmatism. Look at near vision. So if the distant vision is bad, is the near vision good? Is there a mismatch between the two? As I said, retinoscopy, direct ophthalmoscopy, distant direct ophthalmoscopy, these are simple things. Another thing I would urge every cataract surgeon to keep a book, Ishihara's book. You need to keep just 2 books. One is a book on ophthalmology, which you can read when there is in between patients, and the other is Ishihara's test plates. Remember that color vision is not affected by refraction, by media opacities, and by most retinal conditions. So if the patient says he cannot see and in color vision he can't identify the plates, you're straight away eliminating the first 3 causes and you're looking at optic nerve and on. So it's such a simple thing, and you do color vision one eye at a time. So if one eye is normal color vision and the other eye is not, you know that that eye has got an optic nerve issue. So you don't always have to go to corneal topography. If you do these tests, then topography is only to confirm the astigmatism. Then you have, of course, other things like anterior segment OCTs, aberrometries, and you have eye trace. But all these expensive gadgets are not always required. If you have a lens practice and you do an RGP lens over refraction, that means patient is seeing with the best refraction is seeing only 6/18, and you put an RGP lens or a semi-soft lens and he sees 6/9, again you're eliminating the astigmatism there. So it's a good substitute to at least pinpoint the location of the lesion. What about if the lesion is at the back, is in the retina or the choroid? A dead giveaway is metamorphopsia. If the patient has metamorphopsia, usually macular cause, visual field analysis, a careful analysis by you and not by your optometrist. Pick up small scotomas, usually there is a retinal cause. I had a patient who had been barraged with argon laser photocoagulation some 4 or 5 sittings, and this patient had multiple small scotomas which we could pick up, and that was the cause of his this. Then Amsler's grid, again something which we give patients for at home. Use it in your clinic as well. A photo stress test. Photo stress test is nothing except shining a very bright light and seeing how much the vision drops. So if the bleaching of the retina is excessive, the vision drop is more than 4 lines, then you know you're dealing with some problem in the retina. Pupillary defects I won't talk about. And then of course there are additional investigations. My idea of saying this is that if we go through this carefully, the need for all these is not for every patient. So only when you don't find something and you still suspect, then you can do some of these, but everyone doesn't need sophisticated investigations. Moving from the retina to the optic nerve. So again, this is a very underemphasized and over-delegated, the pupillary reaction. Many times you've got an optom who's seen the patient, you've got a busy practice, they're trained only to put drops in every patient, dilate, because sir wants to see if the cataract is there or not. So for sir, the drops are put and the patient comes in with a well-dilated pupil, and then you've missed all this. So don't be afraid to call the patient back on another day to check just for this, because the optom has usually missed this. Again, I talk about color vision, always affected in optic nerve disease. Optic neuritis, it is affected. Early papilledema, it is not affected. So again, when you want to distinguish between optic neuritis and early papilledema, simple tests like color vision helps you. And perimetry, as I said, is again something which is not given its due importance in neuro-ophthalmology. Let's move on to non-organic. Now you found nothing in all this, and this patient has got an eye like this and still says that he can't see. He could very well be a hypochondriac, he could be a malingerer, he could be a Munchausen syndrome. Munchausen syndrome is a chap who loves going from doctor to doctor and complaining about various things. Just the pleasure of meeting doctors gives him a thrill. So it's easy if the patient has got bilateral, moderate or severe bilateral visual loss, it's fairly easy to pick up. Moderate or severe unilateral is again easy to pick up. It's difficult if it's mild to moderate bilateral, and difficult if there is a non-organic or a functional overlay, means there is a genuine problem plus he's exaggerating. Remember, VEP is not always diagnostic. We tend to send patients immediately for VEP. A patient can alter or extinguish their own pattern VEPs, something which is not well known, that a patient can alter it. So a clever patient can alter their own VEP. So it's not always diagnostic that you'll be able to pick up something. So severe bilateral vision loss, observe ambulation. If the patient walked into your clinic quite confidently, he's possibly faking it. If he's wearing sunglasses, he's seen too many Tamil movies, so he's usually faking it. Because if you're blind, why do you need sunglasses? There's no photophobia over there. So he's seen movies that all blind people wear sunglasses, so he's wearing them to come to you. Again, a simple test like an optokinetic drum. If you get nystagmus elicited, that means you move the drum at a speed. Don't move it too fast because the eyes will not move. But if you move it at a regular speed, and if the patient's eye moves towards the stripes and then moves back to catch the next stripe, the vision is at least greater than 3/60. So again, a simple, inexpensive tool which all of us can keep. What about unilateral vision loss? Just the left eye. Patient says, I can't see with my left eye. Vertical prism test. Use a single Snellen's letter, the E chart at a distance. Put a 4 diopter prism base down in front of the good eye. So good eye is the right eye. Put a prism with 4 diopter base down. If the left eye is genuinely seeing less, he will see only one letter because the two eyes are now split in the brain. But if the left eye is seeing less, he will see only one letter. If he sees two letters, one above the other, then he is faking it. To summarize, when evaluating a patient, first determine where the problem is located, front of the eye, back of the brain, somewhere in between, whether it's physical or non-physical. Use common diagnostic tools like color vision, direct ophthalmoscopy, a correct vision field test, and you must prove that the patient is non-organic. It is very wrong to label him when he is not. So take advantage of the vertical prism test. That's one test that I use quite often to find out. Don't get frightened with the case of unexplained visual loss. Don't rush to do a CT, MRI. Nowhere in my talk have I talked about this. Rule out organic causes in the media, retina, visual pathway. Test in your own clinic for functional visual loss, unilateral and bilateral. Keep your questions for later. Thank you so much for your attention. Thank you. I now invite Rashmin.
Thank you, sir. Thank you, Dr. Quresh, for inviting me for this very nicely crafted course. So I'm going to go to the other side and say that patient who comes to us with symptoms which we see quite often, like headaches or loss of vision or double vision, and what are the cases where we should be rushing to say that this patient requires something, and in some instances requires investigation immediately. So this is a case, blurring of vision for the right eye, visual acuity being 6, 9 and 8, right pupil being larger than the left, and little sluggishly reacting. Patient also complaining of headache. So one thing which we need to remember is that when the patient has difference in pupillary size, that's not really a sign of optic nerve disease. When there is anisocoria, when there is a difference in the pupillary size, it is generally an autonomic system problem. It can be either a sympathetic system problem or a parasympathetic system problem. And that's how, this is how the patient looked like. Now see here on the top photograph, you can see that the left pupil, left eye, which patient does not have much of a problem, has a mild ptosis. And there is an anisocoria where right pupil is bigger than the left pupil. So when you have this kind of difference in the size of the pupil, the next step would be to see what happens to the difference in the size of the pupil when the room lights are turned off and when the room lights are turned on. In other words, we want to see what's happening to anisocoria when there is a bright environment versus a dim environment. Here, if you see in a dim environment versus a bright environment, you see that anisocoria, the difference is much more in a dim environment. So in a dim environment, when the room lights are off, normally pupils are supposed to dilate. If anisocoria became worse in a dim environment, meaning thereby that the smaller pupil did not dilate, patient, in other words, is having a sympathetic system problem. So now patient has a sympathetic system problem with the left side. She's also exhibiting a little bit of ptosis. We are dealing with Horner syndrome. Now why it is important for us to know? Because A lot of these patients can come to us with complaints, vague or severe complaints of headache or neck ache. And let's look at it a little bit more in detail. This is another example of patient with left pupil being smaller than the right pupil. Remember, Horner syndrome with pain is a medical emergency. And why is that? The pain can be in different parts of the head or neck. Horner syndrome with acute facial or a neck pain, patient might be harboring a carotid artery dissection. Now, why that is important to us? One in the red tells us that it's important because 50% of these patients in the series which came out from Atlanta, 50% of the patients who had carotid artery dissection, they actually presented to us first. And why is that important? 60% of these patients have permanent neurological damage and 5% mortality rate. So patient who came to us with complaints of headache or neck pain, harboring a problem which can be fatal. And that's the reason why, and 50% of them actually present to us first. The other possibility, Horner syndrome with shoulder, scapula, arm or hand pain. So if patient has anisocoria and is complaining of pain more down, patient might be having Pancoast tumor or apical lung tumor. Again, 20 to 50% of these lung tumors would have Horner syndrome on presentation, and some of them can present to us first. Patient complaining of daily unilateral headache is reader syndrome or trigeminal neuralgia, and generally these patients are managed by neurologists. So that's about scenario number one, patient coming to you with headache or neck pain, and you found anisocoria. The second step would be to find out what happens to anisocoria in a dim versus bright environment. This is another example of anisocoria with some ocular motility problem. You see, again, patient has ptosis of the right side, and I would be checking ocular motility using a torchlight, and you'll find that the eye which has ptosis also has a larger pupil. And when the ocular motility is being checked, you'll find that there is a limitation of elevation in the same eye. So this is another example. Of course, this is much more obvious where you don't really have to do anything. You know that the patient has a problem. But this again is a medical emergency. Patient has a potential partial third no palsy with pupillary involvement. Now, why that is a medical emergency? Because 10% of these patients who have third no palsy with pupillary involvement can actually die before a medical attention, because they can be having aneurysm of posterior communicating artery which present to us first with a third no palsy and pupillary involvement. 50% of these patients can actually pass away within 1 month, and rest of them can have residual neurological deficit. So pupil anisocoria, we looked at two scenarios. One, Horner syndrome, patient can come to us with headache or neck pain, or patient with a third no palsy but pupillary involvement. A lot of times patient who comes at a later age group has a third no palsy, has diabetes or blood pressure, we tend to attribute third no palsy to diabetes or blood pressure. But if the pupil is involved, if there is a suspicion of pupillary involvement, then patient requires MRI or MRA immediately, because that's a potential aneurysm which can rupture and patient can pass away. These are two pupils which generally we end up seeing more in neurology ward and not so much in our OPD, a dynamic oval pupil or Hutchinson's pupil. So if you are caught to see a patient in a neurology ward, and if you find that a single pupil is dilated or it has become oval which keeps changing its shape, you saw patient in the morning and the pupil was oval, and then in the afternoon it became round again, these two are actually suggestive of early or late brainstem herniation. So that's about third no palsy and pupil anisocoria. Another, since I'm also going to talk about motility, another example where we should be a little more careful in a third no palsy is this video is stopped. But if patient has recovered from a third no palsy and you find that there is a little bit of ptosis where the lid is jumping up and down when the patient is adducting or looking down, that's a sign of an aberrant regeneration. Again, a feature that you should not ignore, because aberrant regeneration is generally a sign of compression of the third nerve. Now, these are some of the other cases. Patient complaining of a 40-year-old female complaining of a near vision problem, obviously presbyopic age group, so she was given glasses, but this is what she was having. You can see here the left pupil is little larger than the right pupil. So there is an anisocoria, and you can find here that now I'm examining pupil in a dim room versus a bright room, and you'll find that the difference in the size of the pupil was more well in a bright environment. So patient who has anisocoria worse in a bright environment, ocular motility being fine, patient coming to you mainly for near vision problem, this patient has ADIS pupil. Again, as Dr. Quresh mentioned, it's not necessary that you found this and you need to do urgent neuroimaging. A simple test in your OPD, and you find here that now left pupil, which was larger, has become of normal size. Patient was the diluted pilocarpine drops were instilled in both the eyes, and you find that left pupil has responded, confirming the diagnosis of ADIS pupil. Generally, these patients don't really require any treatment. In olden days, patients were being prescribed pilocarpine to take care of their photophobia and near vision problems, but pilocarpine comes with its own set of problems, and that's why we have stopped prescribing these patients. They just require maybe sometimes near vision glasses and a sunglasses when they go out. So that's about the pupil. This is just a demonstration of RAPD, which is the another set of pupil, as Dr. Quresh mentioned. Any patient who comes with a loss of vision, which is not explained, this is the most objective way to say that it's not cataract or it's not refractive error or it's not retinal problem, but it's neuro-ophthalmic problem. It's the most objective test of a unilateral pupillary disease. And you see, when the torch is shown on the left eye, left pupil, instead of constricting, is dilating, signifying the patient has optic nerve problem in that eye. These are the steps of doing pupillary evaluation, and that should be actually a norm in every patient that we see. And this I have taken from Dr. NJK's presentation, where patient should be looking at a distant object in a dark room, and each pupil should be illuminated for an equal time at an equal angle. To end, I'm going to show a few patients with ocular motility problem. Again, patient coming to you with diplopia, and patient on the left hand side, you find here that he has esotropia with a limitation of abduction in the right side as well as in the left side. So bilateral abduction deficit, there are two possibilities. It can happen in a raised intracranial pressure. So look at the fundus very carefully. Patient may be having raised ICP, or it can happen in the tumors of base of the skull. Versus this patient who has a little bit of lid bump and is not able to look at to the right side at all. This patient had a pontine problem. Ending with this ocular motility problem, where you can see that the eye is not moving at all. So when you have either eye which is not moving, multiple cranial effect or effect in the other eye, those patients would require a neuroimaging. This patient had a problem with a cavernous sinus, which can be either a tumor or infection. So in other words, as Dr. Quresh mentioned in the beginning of the course, a lot of these tests can be performed in the OPD by just using a torchlight or a target. A pupil anisocoria or a pupillary reflex are important tests. Pupillary reflex tells you about optic nerve disease. Anisocoria is always an emergency unless proven otherwise. And ocular motility, multiple ocular motility problem always warrant neuroimaging. In a 6-nerve palsy, which is quite common than the other cranial nerves, always look at corneal sensation. Because even if it looks like just an isolated 6-nerve palsy, if the corneal sensation is gone, then patient might be having infection of the cavernous sinus, which again can be fatal little later in the life. Thank you so much.
No, I think we'll let her, thank you, Rashmin. That was a very, very good overview of simple things like how to do a torchlight pupil examination, how to look for relative afferent pupillary defects, and how much information we can get just from motility and from pupil. Not everyone needs an MRI. Continuing in the same vein, we have Dr. Hemalini will take up headaches and who needs and who doesn't need further testing.
Good morning, everyone. So does every headache require neuroimaging? So we're often faced with this situation where a patient comes to us, either a physician or an ophthalmologist, and we're confronted with this question of whether or not to perform neuroimaging in order to confirm a distinct headache diagnosis. But remember that we live in a resource restricted medical environment, and performing neuroimaging here at the drop of a hat without any appropriate clinical evidence is not justified. So the aim of this presentation is to discuss some clinical scenarios that we come across in our OPD with complaints of headache and how they were managed. Before we get further, let's get familiar with some terms. So what is primary headache and what is secondary headache? Primary headaches are those headaches that don't have a structural cause, and one of the commonest ones are migraines. Whereas secondary headaches are those which are caused by a disease, for example, papilledema, brain tumor, brain hemorrhage, etc. When I come across a patient who comes to my OPD with complaints of headache, my typical workup includes vision, which everyone will do, distance and near, refraction. But what is different is that when required, I do a cycloplegic refraction and even fogging if required. Sometimes I do the refractions myself. Pupils and color vision are a mandatory part of any examination. And what most people forget is doing the cover test. So I think cover test is a very valuable tool when performed properly for near as well as distance to uncover the cause of a headache. Don't forget to check the near point of convergence and also always test the extraocular movements. Undilated fundus is mandatory for any eye examination for any patient, no matter what complaint. Some of the common causes of headache in our OPD which don't require neuroimaging are presbyopia, which is one of the commonest causes you see in a 40-year-old, any refractive error, but more so in astigmatism and hyperopia, patients who have convergence insufficiency, intermittent divergence squints, accommodative esotropias, and migraine. The red flags in headache where you will get a neuroimaging done. So if you have a patient who comes with complaints of headache, who also has some double vision, has unsteady gait, has loss of vision, has abnormal reflexes, appears confused to you, or on the fundus shows some optic nerve pathology, then you will get a neuroimaging done. And the choice of neuroimaging most of the times is MRI only. Before I go on to some clinical cases, just a few words about migraine. So it is a primary headache. The women are more commonly affected than men. They may be associated with nausea, vomiting, blurring of the vision, often described as a scintillating scotoma by the patient. The patient will tell you that they see a cloud which moves from different quadrants of the visual field, and they often are photophobic. But remember that migraine is a diagnosis of exclusion, and neuroimaging is usually not required, and they respond very well to medication. But in some situations of migraine, you want to get a neuroimaging done. So which are those situations? So if you come across your regular migraine patient who complains that there's a sudden change in the frequency or intensity of the headache, or if an aura which lasts for more than an hour, or a headache which is associated with imbalance or difficulty in speech, headache which is brought about by coughing or straining or bending over, or a headache that just does not fit into your typical pattern of migraine, you will get a neuroimaging done. So when you get neuroimaging done in a migraine, what will you see in the MRI picture? So the MRI will show may or may not show a large number of white spots. These are white matter hyperintensities. They look very frightening when you see them, but they mean nothing wrong. Non-migraine patients also have these white matter hyperintensities, and hence no need for panic. But if there is no other finding, simply reassure the patient and advise a suitable migraine medication. Headaches that don't require neuroimaging. So now I'm going to discuss a few interesting cases which present with headache but didn't really require neuroimaging but often get neuroimaged falsely. So the first case is that of a 15-year-old girl, and her main complaint was constant headache towards the end of the day. She also complained of little blurring sometimes, especially towards the end of the day and more while looking at a distance. The vision was 6/6, fundus was normal, color vision was normal, and the pupils were brisk. So this is what she looked like. Now, if you see the video very carefully, the eyes are straight. But if you simply do a cover test, you see that the eye is moving out like you see in this video. And you see that straight eyes is actually an intermittent divergence squint, and she's able to even bring back the eye. So why do patients with intermittent divergence squint present with a headache? So remember that when you have an intermittent divergence squint, towards the end of the day, a muscle fatigue sets in and the patient is no longer able to fuse. Even at that point, momentarily, sometimes a patient may even complain that I see sometimes double vision towards the end of the day. There is a constant effort that this patient makes to keep the eyes aligned, and that's what causes the headache. Why does a patient complain of blurring of vision? There is a constant convergence effort to keep the eye straight because the eye has a tendency to go out. Now remember, along with the convergence, there is always some accommodation. When you have accommodation, there's a slight shift towards myopia. But when you do a cycloplegic refraction, the myopia is neutralized, and most of the times these patients don't require glasses. But many a times, intermittent divergent squint patients directly go to the spectacle shop where an undilated AR shows a myopic refractive error. They are prescribed glasses, but they are not happy, and the headache continues. So how can we help these patients? If the angle of the squint is small, then we can simply give them some convergence exercises. But if the control deteriorates, like what we saw in this patient, then the only option is squint surgery. Needless to say that there's no role of neuroimaging. So this is another patient. Volume dena, please. Volume for the video. Increase the volume. So I'm going to start the video again. Start the video again. Okay. आवाज नहीं आ रहा है.
पहले तो मैंने सीटी स्कैन करवाया, वो नॉर्मल आ रहा है, और फिर बाद में ओपीडी नंबर 26 मैम ने बोला है कि पहले आईज चेकअप करवा लो, मैम क्या बोलती है फिर यहाँ पे आके बता.
So basically, this video is saying that this child had complaints of headache. She went first to the neurologist because the pediatrician referred her to the neurologist. Because of the constant complaints of headaches, which were not getting better, the neurologist first asked to get an MRI done. She got the MRI done. The MRI was normal, and then the neurologist referred this patient to the IOPD, which is where I saw the patient. So when I see the patient, this is what I find. So once again, a simple cover test shows that this patient had an intermittent divergent squint. So the intermittent divergent squint was wrongly neuroimaged, and all this patient required again is some convergence exercises. If not get better, then probably a squint surgery. The next case is that of a 4-year-old who complains of occasional squinting and headache more after returning from school. Typical scenario, vision is normal, fundus is normal, but the cover test showed an intermittent convergent squint more when looking at a near object. When we did a plain undilated AR, it revealed a small amount of hypermetropia, 1.5, which you would think is probably normal. But when you see an intermittent convergent squint or a small esophoria in your OPD, do not hesitate to do a cycloplegic refraction. The choice of cycloplegia in such cases is usually 1% atropine, but if you cannot use atropine, use cyclopentolate. When we did a cyclopentolate refraction, the 1.5 increased to +6, which meant that he had a large amount of latent hypermetropia, which was responsible for the headache. Now, if you see, take a look at the video. This is how she presented. Eyes looked absolutely straight, but you see the intermittent convergence that is taking place. And more so when I'm showing her, not even an accommodative target, but just my finger, and you see that the eye is going out. So why do we get headaches in accommodative esotropias? So remember, a child who has accommodative esotropia has latent hypermetropia. This child wants to see clearly. Because the vision is blurred and because there's latent hypermetropia, they tend to accommodate. But the accommodative effort is a lot, and with every unit of accommodative effort, there is 1 unit of convergence. And hence, when they're trying to accommodate 6x times, the eye straight goes inside. The headache is because of the constant accommodative effort required to see clearly. So once the glasses are given, the accommodative effort becomes 0. Hence, there is no convergence, and hence there's no squint, and therefore the headache becomes better. So the treatment is to explain to the parent and counsel them about the high plus refractive error. Most of the times this is quite difficult because the parents are reluctant to make their child wear glasses. 1, because they're convinced that there's nothing wrong with the vision, and 2, there's usually a taboo around the use of glasses in a 2 or 3-year-old child. Importance of giving the full hemiplegic refraction is not underestimated, because only when you prescribe the entire amount, that's what's going to correct the squint and the headache. Always reassess the squint and the headache frequency with the new glasses after 3 months. The next case is that of a 24-year-old college student. Typical complaints of headache, but is spending almost 8 to 9 hours on gadgets, which is not unusual today. Laptops, mobile phone, YouTube, social media, all of it together, 8 to 9 hours. That associated with late nights. Headaches more common in the evening towards the end of the day and relieved on sleeping. So this patient had convergence insufficiency. Now, as you see in the first video, if I'm looking, he's looking at my finger, he's able to converge, but after a few seconds, he's not able to hold the eye and the eye tends to drift out. So this is convergence insufficiency. They are usually orthophoric for distance, but exophoric for near. And if you see the second video, I'm teaching him convergence exercises where he's able to converge. He's holding the convergence, the eye is tending to go out, but you ask him to hold it there for 20 seconds and then move out. So this can be repeated several times a day. Treatment of convergence insufficiency is simple. Limit the use of gadgets. Amongst all the gadgets, I tell the parents that the TV is the best because it's at a distance, followed by the laptop, followed by the iPad, but the mobile phone is the worst. Take frequent breaks. Try to follow the 20-20 rule, and treat the patient with either convergence exercises or prescribe glasses with prisms. Worst scenario, you can opt for a surgery. This next patient is again a similar patient, 7-year-old, not able to converge at all, and that's the reason why she has a headache. So if I'm looking, she's not able to look at the finger, there's no convergence at all happening. The next case is that of a 12-year-old. He was a myopic and he used glasses for many years. He was an old patient of mine, and the patient had visited me recently 3 months back with a full workup done. His complaint was that, Auntie, I get little occasional headache and sometimes I have difficulty in seeing the blackboard, but sometimes. The vision recorded with the glasses was 6/9 in both the eyes, so I didn't pay too much attention to it, and the AR showed a very small change. I simply prescribed the new glasses. Well, I insisted on a dilatation because he was myopic and there was a change in the refraction, but the mother refused because the child had exams. Plus, I was also very, not very pushy because I had seen the child just 3 months back where an entire workup was done. So I gave the new glasses and I let the child go. The child came back a couple of days later, but with complaints of persistent headache, the headaches which were not going with the new glasses that I had prescribed. The ocular examination was normal, but the undilated fundus this time showed an abnormal looking optic disc, and hence a dilatation was insisted. This is what I saw on dilated picture. So what you see in this picture is both eyes disc edema. Then the next step to do after you see this is a visual field, and the visual field shows an increase in the blind spot suggesting raised intracranial pressure. These were the differential diagnoses running in my mind, but the challenge was, how do I tell the patient who had come for a routine checkup that, look, your child has disc edema or swelling in both the eyes and this child requires neuroimaging? It was challenging. So immediately I lost the patient. 1 week later, the patient came back. The headaches had worsened. The vision had dropped to 6/12. She had gone elsewhere. A CT MRI was done. So now what next? When you see disc edema with an increased blind spot, you don't stop at the MRI, get the MRI venogram to rule out a sinus venous thrombosis. That was also normal. So then we got a CSF tap done, which revealed a high opening pressure. So this child had a benign intracranial hypertension. Now, this child was not obese. So what really caused a benign intracranial hypertension under 12-year-old? So then we went back to the history and asked the mother specifically about any drugs that the child was on. And she revealed that this child was on fluvoxamine, which is a serotonin reuptake inhibitor, for an obsessive compulsive disorder. And he was taking it for the last 2 years without any follow-up. And one of the rarest side effects of this drug is to raise the intracranial pressure. So the drug had been discontinued and the child was given Dimox, and the BIH resolved. The take-home message with this case is that do not forget a fundus examination, even if the patient has come for a simple refraction. I made that error. I did not do the undilated examination, and this is what happened. So to summarize, every headache needs an evaluation on its merit. At the same time, neuroimaging should not be done for each and every case, but yet it should not be discounted and one should not hesitate when really required. Thank you.
Thank you so much, Emalini. That was making things quite crystal clear, and we'll take a few questions from the audience later on this, and I have some questions of my own. We'll go on to Dr. Naveen. Dr. Naveen Jaikumar will tell us about the importance of visual fields as part of general neuro-ophthalmology checkup.
Yeah, good morning to all of you. Thank you, Quresh, for inviting me here today. My talk today is on visual fields from a neuro-ophthalmic point of view, which I will cover over the next 15 minutes or so with 6 illustrated lessons. In between, there will be 12 questions. And of course, we'll have a little plan at the end as to how to approach a visual field when you're presented with one. There are several reasons why one performs visual fields, one being the most common, which is the topical localization of lesions. The other one is, for example, differential diagnosis. For example, if you had a disc swelling with an altitudinal defect, you would say that's ischemic optic neuropathy. But if you had a central scotoma, you would say probably that's optic neuritis. To monitor progression or recovery, Himalini spoke about idiopathic intracranial hypertension. How do I know that the optic nerves are getting better apart from looking at it? Is to do the visual fields, or is it getting worse? In which case, the fields would get worse. And last but not the least, any patient with unexplained visual impairment or some disturbance in vision. But today, let's focus on the first one. So, for the purpose of visual field localization, this is the first concept that I want to put forward to you, is to look at the visual pathway in a slightly different way. 4 regions. The first regions is the outer retina, where you have rods and cones and the bipolar cells. The field defects can be of any kind of peculiar pattern, but importantly, they will correspond to a visual fundus lesion. Moving on to the second area, which all of us are familiar with, which is the optic nerve, but also including the ganglion cells where the optic nerve arose from and the nerve fiber layer. These are very familiar to all of you. You have papillomacular bundles, so central scotoma, centrocecal, the glaucoma field defects, and occasionally the nasal fibers producing a temporal wedge which connects to the blind spot, not to the fixation. Thirdly, of course, the classic field defect which you all are most familiar with, which is belonging to the optic chiasm. You have bitemporal, binasal hemianopias or hemiscotomas, and occasionally, if little posterior to the chiasm where the tract starts, you may get a little bit of incongruous homonymous hemianopias as well. And lastly, this big region at the back, which is the retrochiasmal visual pathway. It can produce a complete homonymous hemianopia on one side, which would just tell you that it is a retrochiasmal lesion on the opposite side. However, if it's incomplete, then you can make certain assumptions. For example, if it's optic tract, you can get incongruous defects. LGB lesions sometimes produce sector-like defects. The radiations produce quadrantopias. And you have these exquisitely congruous defects perfectly matching each other in occipital cortex lesions. So I hope you got those 4, because now we are going to go into a couple of pictures, and I'd encourage all of you to shout this out. What is this? Perfect. Bitemporal hemianopia, and we know all where that comes from. Usually it's a favorite pituitary gland going up and pressing on the optic chiasm from below. And clearly, this is our region 3, optic chiasm. Okay, this system works. Let's try one more. This is a patient who complained of sudden onset of, I am seeing something difficult, not very clear in my left eye. This is the field of the left eye. Any suggestions or points to make here? What kind of defect is that? Think of those regions. Which region do you think it would fit in? Those of you who think it's region 1, lovely. Okay, some peculiar looking defect, you could get it. Muna raised a hand there, so it could be some kind of a retinal lesion producing this. But typical me, am I not showing you everything?
The other eye.
Well done. Now, where is this? Optic tract. This is an incomplete homonymous hemianopia. You can see both the defects are on the left side. This is a left incomplete homonymous hemianopia. But what about the pattern between the 2 eyes? Is it exactly the same?
Incongruous.
It's incongruous. It's almost Perfectly congruous, actually. You look at that stepwise defect that you see, it's called a cookie cutter lesion. You can see literally the same thing happening on the right field as well. And this kind of perfectly shaped lesions usually belong to the occipital cortex. Okay, this is a right occipital infarct. So this is clearly region 4, the exquisitely congruous defects. So my first lesson to you here is perform visual fields of both eyes irrespective of what the patient is complaining of. Okay. Here is one more picture, and what should you ask me for? Okay, here we go. Good, you're learning. So this is obviously the right field because this is where the blind spot should be. Okay. What kind of defect is that? Okay, this is a quadrantenopia, but if it were a quadrantenopia, you would get a similar defect on the opposite field as well, which you're not. So this could either be an optic nerve lesion, area 2, or maybe something within the eye itself, which Munna spoke to you about earlier or raised her hand at least. So this is a chorioretinal scar. You can see the shape of the scar corresponding perfectly to the kind of field defect that you are seeing. So look inside the eye. Okay, so this is region 1, the outer retina. Okay, this one, this is a central scotoma, well done. And that's a centrocecal scotoma connecting to the blind spot. This is a patient who had optic neuritis in the past. You can see the pallor of the discs there. What about this? This is an inferior. It kind of looks arcuate, isn't it? Because one part of it is free, but also it's coming right up to the fixation. Okay, so it wouldn't be wrong to say this is like an inferior arcuate defect if you had to describe it, but coming right up to the fixation. So this is almost in the similar flavor as an altitudinal. This patient had an ischemic optic neuropathy, and you can see the upper pallor corresponding to the inferior defect. Okay, so this is region 2, your optic nerve. Good going so far. Now this you all know, just to revise, what is this? Bitemporal hemianopia. Where is the lesion? Okay. Why do you say it's a bitemporal hemianopia? See, visually your eye tricked you, isn't it? Okay. This is how it should be, isn't it? So always when you project fundus photographs on the screen, you always put the right fundus on the left side and the left fundus on the right side of the screen, because that's how we would normally see it. But in case of a visual fields, you have to imagine as if you were the patient. Okay, put the right field in front of your right eye, the left in front of your left eye. So this is a binasal hemianopia. So always view fields as if you were the patient. Okay, so binasal can be due to many things. The classic one used to be the giant aneurysm, but most often you can get problems within the eye, and rarely you can even get congenital binasal hemianopias without any defect whatsoever. Okay. This is a patient that came to me. She's a known patient of pituitary adenoma, hyperprolactinemia, and she came off several years from 14, 17, and 18. Optic nerve function good, visual acuity good. I used to do serial fields, and then she was lost to follow up because of COVID and all, and she came recently. Slight temporal pallor now. Color vision is still good. This is the defect. Now you can clearly see there is a kind of a field defect only in the left field, but respecting the vertical meridian, which you can see. This is a huge expansion of the tumor. It's gone right up. This is the optic chiasm, which is slid down to one side, and there is pressure there between the optic nerve and the optic chiasmal junction, affecting the inferior nasal peripheral fibers of the contralateral eye, producing a left-sided field here. And if you look once again at the earlier field, which I showed and I passed by very quickly, 2018 also shows that. Very, very fine lesion there. This is a classic traqueous junctional scotoma. The message here is, in a unilateral optic neuropathy, the neurologically more important field is the field of the contralateral eye. Okay? And one more lesson here as well. Usually we do central 30 degrees or 24 degrees for almost every field in neuro-ophthalmology. Will get covered with that. But you might miss a turquoise because these involve the peripheral nerve fibers. So the field effect will start in the periphery and then progress to the center. So just keep that in mind. Okay. We now move to this kind of defect. You can see very clearly it's both affecting the left side. It's incomplete. It's a homonymous hemianopia on the left side. It's incomplete. It's unusual. It's not a quadrant or anything. This is involving a sector. Okay, so this kind of defect is called a sector anopia, and this is due to lateral geniculate body lesions. Okay, that is the patient here. You can see that small lesion there in the lateral geniculate body. Sector anopias can affect the upper parts as well. So one more lesson here, as I told you earlier, incomplete homonymous hemianopias, you can localize it to different regions of the retrochiasmal pathway. Okay, here is another homonymous looking defect, largely sparing the center, mostly involving the upper and lower hemifields there. Okay, so these are the four quadrants, four sectors involved. So this is known as a quadruple sector anopia, and this is also lateral geniculate body. And this unusual patterns is because of the unusual orientation of the nerve fibers in the LGB and their dual circulation from the middle cerebral and the posterior cerebral arteries. Okay, this one is homonymous. It's involving one quadrant. So this is a classic pie in the sky defect due to involvement of the inferior radiations in the temporal lobe known as the Mayer's loop. This is the lesion in that patient. And here, just the opposite, you have a pie on the floor, and you can see that again, temporal lobe to parietal lobe now. Parietal lobe lesions, upper radiations producing pie on the floor. My last lesson is always perform confrontation fields, especially when you have poor visual acuity and you cannot do formal fields, because they will give you as good an information as a formal field testing. Color confrontation is also useful because dyschromatopsias respecting the vertical meridian are as significant as an actual hemianopia. And lastly, there's a condition called hemi-neglect, which you can pick up only on confrontation, as which you can see on this video. Can we have the sound here, if it's possible? So this is a patient who says he can't see on the left side, okay? And yeah, he can't see on the left side. So they're doing confrontations, and his wife tells he can't see anything this side. He sees only on the right side. So on confrontation feeds, you can initially see that the left field is missing, okay? But when he moves both hands to the right hemifield, which is the seeing part of it, watch what happens. It's not coming here. Okay, let me describe it to you. Imagine you were the patient, you're not able to see on the left side, okay? So what he did is he moved both the fingers to the right hemifield, okay, to the seeing area. So now when he puts up a finger like this, patient says, yes, I can see this, and yes, I can see this, yes, I can see this side, yes, I can see this side. But when you do both, when you put both together, he says he can only see the right. Even though both hands were on the seeing area, he seems to neglect the left stimulus every time there's a simultaneous presentation of stimuli. And that is a hemi-neglect, usually pointing to a right-sided parietal, a left-sided parietal lobe lesion, okay? So this is one important reason for doing confrontation visual fields. My summary slide is an algorithm. So always when you have a patient who's come to you with their fields, put it the right way in front of yourself and decide whether it's a unilateral or a bilateral one. And if it's unilateral, it's usually retina or optic nerve. If it's bilateral, the question arises, is it respecting the vertical meridian? If it's not, it could be retina, optic nerve, or even that junction that you saw, which sort of goes away from the vertical meridian. But if it does respect the vertical meridian, you're dealing with a hemianopia. And a hemianopia comes in two flavors, homonymous and heteronymous. The heteronymous is, of course, the bitemporal and the binasal hemianopia. As far as the homonymous lesion is concerned, defect is concerned, ask yourself whether it is complete or incomplete. If it's a complete, then it's obviously on a contralateral side, there is a retrochiasmal lesion. But if it's incomplete, then you can get into whether it is incongruous, is it involving a sector, is it involving a quadrant, or is it absolutely congruous, in which case it would be the occipital cortex lesion. I hope in this quick thing we've kind of covered some important points so that you don't make too many errors while interpreting visual fields. Thank you very much for your patience.
Thank you so much, Naveen. I think all our speakers have been outstanding in trying to bring the whole complex field of neuro-ophthalmology and make it less complex, less mystifying, and trying to see how much you can solve in your own clinic as general ophthalmologists, armed with little else except your common sense and a little bit of thinking power to be used. If there are any questions from the audience, we have time to take them now. Otherwise, I will ask questions to the speakers. Yes, go ahead.
Sir, in case of temporal pallor, sometimes the visual acuity is normal, color vision is normal, fields is also normal. So we usually label it as nutritional pallor. In those cases, when is the imaging indicated?
So the first thing is the temporal side of the disc is generally relatively lighter in color than the nasal side of the disc. So temporal pallor can be a normal appearance of a disc. When do we say a pathological temporal pallor? If I tell you I had a patient with temporal pallor, I'm trying to tell you that that patient has some optic nerve problem. So that's what it generally means. So if you had pallor with signs of optic nerve dysfunction, defect in the pupil or a color vision defect or a field defect, that is a pathological temporal pallor, and then you have to deal with that accordingly. Okay. You don't need to do MRIs for every patient with temporal pallor, because I'm sure about 20-30% of the funduses in this room itself will show a light temporal pallor of the disc.
So the other important adjunct to what Dr. Njike said would be OCT. If you have a doubt, if there are vague symptoms, or a patient says that there was some blurring in the past, or you feel, so OCT, now if disc appears pale, but if OCT on the first visit is absolutely fine, you know maybe you're dealing with what Dr. Njike said, because the color of the disc is also dependent upon the illumination that you're using to see the disc. Yes. The status of the lens, whether there is a nuclear sclerosis or there is a pseudophakia. So whether it's an appearance or it's a pathology is a question. So when you're in doubt, you can do OCT. In fact, get the patient back again and do OCT again and see if there is any disturbance, because there are certain neurological disease which can have, though there is nothing happening in the eye, but they can still cause a retrograde problem in the RNFL, and they can exhibit temporal pallor.
Okay, thank you, sir.
I would flip your question the other way around, which is also important, because quite often we deal with cataracts with nuclear sclerosis, which can actually mask a temporal pallor, because that yellowish orangish glow makes the disc look kind of normal, and then you'd be kind of surprised after the surgery that there is a temporal pallor and the patient's vision hasn't improved very much. So you need to be careful in assessing the disc, especially when the patient has nuclear sclerosis. And I think the OCT would come in useful there as well.
So one more question, sir. So in very early papilledema, so especially in pediatric cases, before is the venous dilatation is more sensitive indicator for papilledema or blurring? Sometimes we get pediatric cases, especially if there is an acute rise in intracranial pressure like VP shunts failures, there will be acute rise, and edema, it takes some time to appear or may not appear. So in those cases, how to go about it, sir?
Actually, venous dilatation is not really a sure sign to say that the patient has papilledema or does not have papilledema, because the normal population also, some patients may not have, there is absence of the venous dilation. So it's a very non-specific sign.
So,
really. So you have to clinically kind of correlate as well.
So when to say it is a papilledema, early papilledema? When the disc edema appears or hyperemia appears.
This blurring of the nasal margin of the disc.
Blurring of the nasal margins of the disc, and for me, I always look at the appearance of the blood vessels on the surface of the disc, because you can get a little bit of obscuration, a little bit of fuzziness of the circle, which tells you it's a true disc swelling. If you had a drusen, for example, it may look crowded and elevated, but every little vessel on the surface of the disc would be crystal clearly visible.
So in fact, again, the opposite. If I see a venous pulsation, it's surely not papilledema. But if I don't see a venous pulsation, it has no meaning.
Okay, thank you, ma'am.
So you were telling about the junctional tumors. I just want to know, normally we go in for a field test as a 32. So the early ones, how do we go about with the test? So
as you can see, even in that patient who had a pituitary adenoma, the 3-4 years that I'd been seeing her, all the central fields were actually fine. So we didn't really follow up. And normally in these patients, the neurologist would be doing a serial scan also to make sure. But yes, if you're going to do if the patient had no complaints and a normal disc and a normal optic nerve function and a normal 30-2, you just follow up. You probably miss that tumor.
Okay.
But at some point in time, it's going to cause a pressure. And if a patient is starting to complain of some visual disturbance in that eye, like a field, I'm not able to see very clearly, and if the central vision, or even if there's an optic nerve kind of a defect in one eye, please look at the other eye. And if your suspicion is higher, do a 60 degrees.
Okay.
That way.
So the general dictum is that if you know in the fundus that there is some disc issue, so disc appears pale or disc appears edematous, most of those patients, even if you do 24-2, you will get the answer, because you, generally speaking, you're not expecting a peripheral defect. Most instances, a 30-2 also would give you answer, except where patient is complaining of symptoms which you are not able to really correlate with your clinical picture, is where you should be thinking of 60 or even 120.
Thank you, sir. Thank you.
Rashmin, for the benefit of the audience, what exactly are these numbers that you're throwing for cataractologists who have never done a visual field? What is the difference between a 24-2, 30-2, 60-2, and the good old arc perimeter that we used to use?
So basically, it's the degree of the field that you are testing. Now, why do, I mean, as the question was, why don't you just do 60 or 120 in everybody, so that there is this debate that you'll miss out on the peripheral part. It's the testing, how many points you are testing. If you keep doing 60 or 120, you are likely to miss more prominent disorders in the center. So in fact, conversely, there are a lot of these patients where you even do Amsler charting. You'll discover central scotoma much more, or even 10-2, you'll discover those central scotoma much more.
It's a matter of whether you want to zoom into a field or zoom out of a field. So I generally use 120 screenings for patients in whom there's very little likelihood of a field defect. For example, if a patient came with a headache and is very bad and there's complaint of some vague visual problems, I would do a 120 screening first, because everything else was normal in the eye, including the disc and the color vision, etc. So as a quick screening method where I don't expect to find a problem, 120 screening works fine. But in a patient who already has a problem where the disc is a little pale or it's a little swollen or something odd about the disc, and the patient's vision has also gone down a little bit, then a threshold strategy works, which means a 24 or a 30 degree.
So how often do you do confrontation in your OPD? Do you do it for most of your patients?
I do it for every patient in whom I'm not able to do a formal field test. Every patient.
So the confrontation, I think, patient who complains of headache and you're not really able to, you're not very sure it looks normal, it's better to do confrontation. Patient who are not ambulatory, patient who would not go through, patient having a neck problem, who cannot sit for 10 or 15 minutes, patient who cannot, would not be attentive, would not responsive. There the confrontation works the best.
So thank you for an amazing session, sir.
Yeah.
So basic question, like sometimes when the examiners comes, especially in postgraduates, what is the minimum visual acuity required for subject the patient for field examinations in terms of orthopedic perimetry, like for both glaucoma and neurological fields?
Yeah, so 660 is where you would get a meaningful information. That is for the exam point of view. In the clinic, sometimes you can end up doing fields even in 3 by 60 by increasing the stimulus size, and you may get the pattern. Remember, neuro-ophthalmology is a little different from glaucoma. Glaucoma, you look at mean deviation, pattern standard deviation. Neuro-ophthalmology, you're looking for patterns. You're looking at, so even 3 by 60, you might end up seeing a predominant temporal defect or a temporal defect which is respecting vertical midline.
Thank you.
Yes, ma'am.
Sir, would there be an approach to see how the central defects are affecting the areas? Like there could be a centrocecal defect, there could be one with optic neuritis, but then there could be one where visual cortex at the tip is involved. So is there an approach to that, macular, like central defects?
Yes, so there was a very interesting case with very, very tiny defects. If you look, you may just get a dot kind of a defect. In an optic neuritis, remember, this, you correlate it with the visual signs. The patient would have complaining of a visual acuity problem. There may be color vision loss, which will not be there in an occipital cortex lesion. Conversely, you raised an important point. Sometimes patients just have a dot kind of a defect and you really do not know what it is and they'll be bitterly complaining. There was a patient like this who kept changing their glasses and meeting hundreds of doctors until they actually did a 10-2 and you literally magnified that 30 degrees this much and then you could see that that little defect was actually homonymous.
Hemiscotoma.
And as hemiscotoma, and the patient had a macular ischemic, a small little lesion there in the occipital cortex. So I think it's good to choose carefully what you want to do, and there's no harm and no shame in sending the patient back or calling them another day to do another strategy for the field.
Thank you, sir.
My question is to Dr. Naveen. As you shown that one patient you followed up in 2018, there was a peripheral defect in the sector. Then in 2023, the patient came with that. So considering that the pre-perimetric changes are there in the RNFL, so we are serially following up the patient of pituitary adenoma by MRI or by field as a neuro-ophthalmologist or ophthalmologist. So what is your take on following up these patients with RNFL? Because that can be a cost-effective way of following them pre-perimetric changes. So what is your take on that?
It's that's a great idea. In fact, looking back on that patient, we should have probably done a baseline OCT RNF at least when we had the chance. Sometimes I do advise it, but for practical reasons, the patients disappear and don't come, and various other non-medical reasons are there for this. But yes, I would agree with you. But again, we need to choose because you don't need to, again, like doing MRIs, you don't need to subject every patient to an OCT RNFL. That's the thing.
So
That's
I
my
think
point.
GCC is even earlier than RNFL for these patients. The problem are twofold. I feel that OCT at the moment is not as mature as HVF. Would you base your decision completely on fields you're going to base your decision? OCT for follow-up, I take your point that it's the same patient. If the same technician does it and same machine does it, maybe you'll be able to take decision saying OCT is stable, so it is stable. But I would still feel, I mean, I know some of the glaucomatologists would also like to chip in saying, would you base your clinical management only on OCT? I'm not very sure.
Okay. Rashmin, this is a question for you. I have a patient, adult, with an isolated sixth nerve palsy. He's non-diabetic, no other risk factors. He's about 65, and he just came in because he couldn't see one side. What would you do for this patient?
Yeah, so there are two parts to this answer. One answer which a lot of us would give when we are in the conferences, and the other answer is one which we would give it to the patient. And I mean, before I go to the real sense, one of our mentors used to always say that, oh, there is a third nerve palsy and a patient is diabetic, hypertensive, a mentor, sixth nerve palsy, a mentor from US. So you say, okay, your nerve palsy, you are saying all this. So you'll observe the patient. Everybody will say, yes, we'll observe the patient. And then that mentor said, what if the patient was Barbara Bush, president's wife? would you still go ahead and tell her that you'll observe or you'll go ahead and do the neuroimaging? Now, coming to the question on a 65-year-old male with isolated, one thing I'll determine is whether it's a isolated six nerve palsy.
Correct.
Cranial sensation, corneal sensation normal, no other normal nerves involved, visual acuity normal, optic discs normal. Both possibilities, patient can be observed, but if I'm observing the patient, if I'm not doing neuroimaging, I'll keep seeing the patient every week to make sure that it is remaining isolated at least for 1 month. Once 3 or 4 visits and there are no other signs, I'm sure that there is nothing else happening. The reason being, there have been reports, though it is rare, there have been reports that isolated six nerve palsy in a vasculopathic risk factor, vasculopathic patient also turned out to be patient with brain tumor. So I would follow up the patient regularly if I'm not doing neuroimaging.
Just to add to your answer, Ashmin, that I would also see the fundus, because I want to rule out that there's no disc edema, because this isolated six nerve palsy could actually be a false localizing sign.
Absolutely.
Yes. Just one point I'd just make here. If you look at this whole thing about do you do MRI for all cranial nerve palsies and things which crop up in various meetings, I think it's for as far as third nerve palsies are concerned, I think they all deserve an MRI with an MR angiograph, irrespective of age. As far as the other two are concerned, I think I would leave it to your clinical decision making and follow up to decide whether you need to have an MRI. Just remember, in terms of seriousness, third nerve tops the list, and then the sixth, and then finally the fourth, which is mostly a congenital or a traumatic cause.
But I must say that our threshold for doing neuroimaging in these nerves have now slowly coming down. So there have been instances where just to make sure that everything is fine, neuroimaging is being done. Yeah.
Everything changes if you got multiple cranial nerve palsies. So if it's a third, fourth, sixth, or it's a third and sixth, and you don't know how to elicit a fourth. But if it's that, then you're looking at more dangerous conditions. You're looking at the cavernous sinus, you're looking at the optic nerve entry, the fissure, especially if the second is also involved. So then your threshold for asking for neuroimaging would be much lower in these cases. Yes, Maya.
So this is again a case of pituitary tumor. First came to me around 3 years ago. One eye was nil PL with complete pallor of the disc. Other eye also had disc pallor, vision 6, 9, 6, 12. Immediately did a field for him at that point of time, which showed a definite hemitemporal scotoma. So imaged him and he was diagnosed with the pituitary tumor for the first time at that point of time. Underwent neurosurgery, debulking, they couldn't remove the entire thing. And since then, he has been on regular MRIs. The latest MRI again has shown growth, which the neurosurgeon has advised surgery, but the patient is not keen for it. And he's serially been doing his perimetries with me to see if there's any progression on the perimetry. So what sort of approach as an ophthalmologist do I watch on that field? Progression for a neuro-ophthalmic field is something which we are not to this thing as compared to glaucoma. So how should we go about that?
I have exactly the same patient, Rashmi, before you answer. A kid with a craniopharyngioma whom they operated. And now the MRI seems to show a recurrence or an increase, and they've been advised radiotherapy. So the radiologist the radiotherapist has advised radiotherapy. So they've come to me to decide. The field looks the same as before. Your turn.
Yeah, and the other parameter which can be looked at, as you very rightly said, glaucoma, you have patterns. So a mean deviation number, if it's consistently going down, so you know that even if the pattern, especially if patient already has a clear-cut temporal defect, there is nothing much to be, which can be compressed. So a mean deviation number is one factor which sometimes you look at when the pattern is not very clear.
Are we looking at any progression to the other side of the visual field?
If there is any worsening of the field, then the answer is very simple.
Yes.
But if it's looking exactly the same, I don't think most of these tumors which affect the optic chiasm are benign. Almost all of them, in fact. So I would probably wait. But as you said, OCT is useful. I think GCC is useful. You take in the other parameters, the other investigations also before you take a decision.
Nerve had pallor, so I'm
but
sure
if you're not doing anything, I think it's up to us to follow these patients very closely and frequently.
Right. So 3 monthly perimetry is what I'm doing, and I'm not seeing any change. But he's really...
I would consider that reasonable.
Yeah.
Sorry.
This is a Just a quick comment about the headache. If the side of the headache is switching, it's on the right and then the left, then it will be a benign a migraine. But if it's constantly on the one side, then we have to worry there will be a pathology. So that is also an important to look into the cases of headache. Secondly, what Vikas said that OCT RNFL changes would appear before that the field effect. But the compression in in this pituitary is in the chiasmal area. So what we will get is a descending type of optic atrophy. So RNFL loss to appear on OCT will take a time, while the field is a functional investigation. So that defect will come appear before the OCT which is an anatomical assessment of RNFL. So that would be the one point.
Just to comment on Dr. Quresh's talk on unexplained vision loss, one, as he very rightly said, that always give a benefit of doubt to the patient before you label a patient as a functional vision loss. And a lot of these patients who appear to have a functional vision loss, everything being normal pupil, even they warrant a regular follow-up and sometimes even electrodiagnostic test, because some of these white dot syndromes like Azure would be notorious, patient would appear, everything will appear normal initially, and either a ERG changes or a fundus changes will appear a little later.
Also, early dementia can sometimes be picked up by an ophthalmologist by simple something called simultagnosia. That means that you show a pencil and the patient says pencil, you show an eraser, he says eraser, you show 20 objects and he identifies them. But you put 10 objects together and ask him to speak and he's blank. He can't identify when they're all put together. This is one of the signs of early dementia which we can sometimes pick up.
Dr. Quresh, how often have you seen dry eyes as a cause of unexplained visual loss in your practice?
I think it's still, in spite of so much being talked about and so many pharma companies coming out with the products, it's still underdiagnosed in this. More than drop in vision is the concept of fluctuating vision. If a patient comes to you saying that he sees better at some times and worse at some times, check about when he's seeing that. If he's a computer programmer and he's doing it at the end of the day, his vision is blurry and worse, that's because his blink action has gone down so much by the end of the day that the tears are not lubricating the corneal surface and his vision is down. So more than drop in vision, a fluctuating vision which is different at different times of the day, different on holidays and different on work days, gives you a clue that there could be a dry eye element in this. Thanks, Emmanuel.
Actually, one quite common symptom that I found patients telling us is they do complain of that blurred vision and a slight monocular diplopia kind of a thing. But they say that they blink and close their eyes and open it and it clears up. And then again, it gets a little blurred. It's classic dry eye, actually. You don't need to do anything else. Certainly not an MRI.
Yeah. If there are no further questions, thank you so much. We've had an excellent audience and a very interactive session. I thank all my speakers for more than rising to the occasion and really raising the bar. We'll have this again next year, hopefully. Thank you so much.
Thank you all.